I am here now with Professor Elisabeth de Vries. Thank you so much for sitting down with me today. So you're here at this conference. You've come all the way from the Netherlands. Explain why you're here.
I'm here because I was invited to give the Wagner lecture tomorrow, and I'm also here because I'm very much interested in using PET imaging for my own research as a medical oncologist.
What first ignited your interest in molecular imaging?
I think it really started because I thought that doing molecular imaging might help you to tell where our medicines are going. So we measure blood samples to look at the levels of a drug in the human body. But it would be much nicer if you can really see where the medicine is going. And especially now that we have, for example, monoclonal antibodies that are specifically targeting the tumor. I was intrigued whether getting insight on what these medicines are doing when you look at the whole body distribution, whether that would help. And I think it definitely helped that I have in my own institution a very active nuclear medicine department and great collaborators and people in the pharmacy department also excited about developing new traces. So that's how it started.
So how has that changed decisions being made?
Well, that's not that easy. I mean, because then you're really making decisions for your patients. I think what has changed over the last years for oncologists is that apart from FDG PET, looking at glucose consumption, we now have already for quite some time the DOTA PET imaging and now the PSMA imaging, which helps to stage patients. I think what's really nice is what's happening now in nuclear medicine, that they use this imaging with DOTA and with PSMA as a selection tool to decide whether patients are eligible for lutetium dotatate or lutetium PSMA. Now, that kind of approaches we do not yet have for decisions in medical oncology, so that you pre-select your patients for a certain treatment. I think what's new is that the FDA now approved FAS to do FAS PET and to allow you to that way determine estrogen receptor expression. And we just 2 weeks ago published a paper in the Journal of Clinical Oncology where we really validated that it does help you to do FAS-PET to determine the estrogen receptor status in newly diagnosed metastatic breast cancer patients. So I think that opens the field to potentially many new opportunities.
And how does that improve the quality and effectiveness in cancer treatment?
Well, that asks for really careful trials to prove that it's meaningful for your patients. But I think what the special thing about PET imaging is that because we often do biopsies on the patient, that tells you about a little piece of one lesion. If you can do PET imaging and it's reliable, it gives you this whole body information. So what we often see, what is very striking, is heterogeneity in tracer uptake, in expression of a certain target. So if we are going to be brave, then we are going to design trials where we take into account that certain lesions most likely won't benefit from a certain treatment, systemic treatment, and others would. And probably we are going to decide that certain lesions should be operated upon or should receive radiotherapy. So things like that, I think it might really help. Then molecular imaging might also serve as a biomarker up front, but it's only one tool and maybe we need more tools. Maybe we can combine PET imaging results with circulating tumor DNA, etc. So many more traces to come. I think huge opportunities to try to explore what we can do to improve better selection for patients.
That's actually very exciting. Thank you for explaining it to someone like me who doesn't necessarily understand all this, but the way you described it really sounds very promising.
Thank you.
Thank you so much for sitting down with me.
Thank you.
All the best.